Now let's move on to type II hyperlipoproteinemia, which is one of the most important and commonly tested types. In the Fredrickson classification, this type is further divided into type IIa and type IIb. Type IIa is called familial hypercholesterolemia, while type IIb is known as familial combined hyperlipidemia. The key difference between the two lies in which lipoproteins are elevated. In type IIa, only LDL levels are increased. In type IIb, both LDL and VLDL are elevated, so cholesterol and triglycerides go up together. Now, what's the underlying problem here? In type IIa, there's a defect in the LDL receptor, or sometimes a mutation in a polypoprotein B100, the ligand for that receptor which uptakes the LDL into the liver cells. There may be also a gain-of-function mutation of the PCSK9 which degrades the LDL receptor. Because of any one of the genetic defects as mentioned earlier, the body can't clear LDL efficiently from the bloodstream. As a result, plasma LDL levels rise dramatically, leading to high total cholesterol. Now let's move on to the clinical features of type II hyperlipoproteinemia. The most characteristic and classic finding is the presence of tendon xanthomas. These are firm, nodular, yellowish swellings that develop over tendons, most commonly on the Achilles tendon, but they can also appear on the extensor tendons of the hands, the elbows, or even the knees. These xanthomas form because excess LDL cholesterol in the blood gets taken up by macrophages, forming foam cells that accumulate within the connective tissue of tendons. It's essentially visible cholesterol storage right under the skin. A hallmark feature of familial hypercholesterolemia or type IIa disease. Next, you have xanthelasma palpebrarum. These are soft, yellow plaques seen on the eyelids, especially near the inner canthus. They're composed of lipid-laden histiocytes and, while they can occur even in normal individuals, their presence in a young person should always raise suspicion of an underlying lipid disorder. Another important clinical clue is corneal arcus, also called arcus senilis when it occurs in the elderly. It appears as a grayish-white ring at the periphery of the cornea, caused by cholesterol deposits in the corneal stroma. But here's the key point: when you see a corneal arcus in a patient below 40, that's pathologic, and it strongly suggests familial hypercholesterolemia. Now, the most serious and clinically significant manifestation is premature atherosclerosis. Because of chronically elevated LDL levels, cholesterol progressively deposits in the intima of large and medium-sized arteries, forming atheromatous plaques. This leads to narrowing and hardening of arteries, compromising blood flow. So these patients are at a very high risk of early-onset coronary artery disease, sometimes presenting with angina or even a myocardial infarction in their 20s or 30s. The same process can also affect other arteries, leading to carotid disease, peripheral vascular disease, or even aortic root involvement. So, to summarize the clinical picture, type II hyperlipoproteinemia, especially type IIa, presents with tendon xanthomas, xanthelasma, corneal arcus in young individuals, and most importantly, a marked predisposition to premature atherosclerosis and early cardiovascular events. As for management, it starts with lifestyle modifications. Low-fat diet, regular exercise, and weight reduction. Pharmacologically, statins are the first line. They reduce cholesterol synthesis in the liver. Ezetimibe can be added to reduce intestinal cholesterol absorption, and for resistant or familial cases, PCSK9 inhibitors like alirocumab or evolocumab are highly effective. In severe, homozygous cases, LDL apheresis is used, which clears of LDH from the plasma. Or newer agents like lamivudine may be considered. So, to summarize, type II hyperlipoproteinemia is all about LDL elevation, leading to cholesterol deposition in tendons and arteries, and a high risk of premature cardiovascular disease.